as I continue to abduct, and I continually externally rotate, and I continually externally rotate, until I take it as far as it'll go. And that's when the reduction occurs, is right at the end of range of motion, around 160 degrees, and full external rotation. Again, when I had to do this in Columbia, we also had someone pushing the scapula medially to also do scapular manipulation, which can be combined with any other technique, where you're adducting the scapula. Thank you very much. Okay, we had one more thing to do, so stay right where you are. See. Self-reduction. Come on back up. Go ahead and put your shirt on. Thank you. Thanks. Self-reduction you should also know for the exam, and so this is something you teach people who've had dislocations. You don't typically teach people unless they've had dislocations, because this is for the recurrent dislocation that you do this. And you can do it on the ground, you can do it on a table, and basically it works like this. You can have the patient get into this position with the elbow over the knee. The elbow's bent. I'm treating this side. You can do either side, doesn't matter really. And you simply lean back. And you gotta relax. You're by yourself now. You don't have someone else to help you, so you slowly breathe deep. And the more you lean back, eventually you can distract the humerus away from the glenoid so that it's over that lip. And then as you release the pressure, it pops back in place. I had to do this on myself 3 times before I had my surgery 2 decades ago. And so kind of interesting process. Slow, deep breathing, stretch back.
Can you show that facing us?
Yes. Just like this. Lean back. Okay. Slow, deep breath. Notice the elbows bent. And the key thing is to relax as I'm distracted. Pull the humerus away from the glenoid, and then it can pop back into place properly. So remember, here's the glenoid, here's the humerus. I need to distract enough so that when I release the pressure, then it pops back in. Remember, the humerus wants to be in the right position. Okay, then we have adjustments for the glenohumeral joint. And let's see, I need to bring someone else up here. You guys already did it. None of it got it. So would you come up here, please? And take your shirts off. And let's get some of these. And ask you to line your back. Okay, so now we have a superior humerus, and so you should know superior humerus is contraindicated if you have inferior instability. You should know how to test for inferior instability. You should know that adjusting the superior humerus can benefit impingement syndrome, and there have been studies about that. We do this in various positions. That's a cool watch. And so now I'm going to stabilize the humerus, not the forearm, but the humerus. I'm going to take a thumb web contact, and you should feel very carefully. I'm lateral. We will be palpating your patients to see exactly where you are. You should be lateral to the acromion. And then in a 90-degree position, you simply stress from S to I and then thrust if it's fixated. That's at 90 degrees abduction. We can also do this at 90 degrees flexion. I'm doing it on this side so people can see a little better. So when I'm on this side, testing him in 90 degrees flexion, he can have the hand on the opposite shoulder, he can have the hand behind the neck, depending on what we're trying to do. I'm going to interlace my fingers. If it's a woman, she's going to cover the breast. So I got to feel, and we're going to feel where your contact is. Very specific is important. I'm distal to the acromion. I'm interlacing my fingers, just on the superior aspect of the humerus and distal to the acromion. I'm keeping them at 90 degrees flexion. I'm not bringing him like this, keeping him at 90 degrees flexion, and I simply stress and thrust from S to I. Questions?
Can you show the first one from that side too?
Yeah. Contact like this, stabilize, stress, thrust. Okay. Have you sit up. And we're going to have you sit facing this way. This way, but at this end. Now, important, it has to be at the end of the table, so I can be in the proper position. You're good, just like here. If he's sitting here facing this way, I can't be in the proper position. Points off for not getting him in the proper position. And why is this correct? Because now I can get like this, because the table's not in the way. scissor stance. If I were treating this side and you're bending forward like this, you're going to screw up your back. You're not going to be able to pay your loans, and that looks bad for us. Okay, so your positioning is important. Again, I could have this hand on the opposite shoulder or the hand on the same shoulder because I might be internally or externally rotating him. Let's do it in this position this time. And let your shoulder just fall, let your arm fall onto my shoulder. I'm going to interlace my fingers just distal to the acromion, and I would stress and thrust from my stomach. Again, you need to know about contraindications. Questions? Take a look. Superior humerus. Thigh contact you can cross out. We're not going to ask you about that. Anterior humerus, supine, and seated in various positions. Okay, so you line your back once more. So now, again, you should know about contraindications and indications. And so for an anterior humerus, we're going to stress and thrust in a posterior direction. And we can do it like this, and have you scoot toward me just a little bit. So I want scapula on the table. I want the humerus not on the table. You can even come just a half an inch toward me. That's perfect. Broad contact here, not a specific contact. Broad contact on the humeral shaft, and I would stress and then thrust from A to P for an anterior humerus. Very simple like that. And of course, what we know is that they're not unstable in this direction. So the push-pull test is negative. This is the test that's negative, which would allow me then to do an adjustment in this position. Remember, you can modify this one as well by varying the position of the humerus to get more of a medial to lateral stress in addition to the P stress. And that's not going to be tested, but just a piece of information. Anterior humerus. You can also do an anterior humerus adjustment. We're changing positions like we did with other situations, because depending on how the cartilage contacts could depend on where the fixation is. So you might be fixated in this position but not in this position, or in this position but not in this position. That's why we evaluate and test in multiple positions. So for an anterior humerus at 90 degrees flexion, I'm going to stabilize the scapula just like we did before. Broad contact, straddling the spine of the scapula. And I'm going to stress and thrust from A to P and lateral to medial. No I to S yet. Okay. Anterior humerus at 90 degrees flexion. Now this is going to internally rotate, stretching the posterior structures. This is going to externally rotate, stretching the anterior structures, which could moderate and determine which position you might prefer to do. Always bring the elbow medially, so you have a medial to lateral stress, because that's the shape of the glenoid in that position. So anterior humerus. Posterior's next. I'm just checking. Good. Posterior humerus, and then we'll switch again. Okay, posterior humerus, have you behind your stomach. Completely analogous. Posterior humerus, we'll just take this arm here. We're going to hold his arm at 90 degrees abduction. We're going to make sure he doesn't have anterior stability. Apprehension test is negative. Broad contact on the humeral shaft. And I'm going to stress and thrust from P to A. A little bit of distraction is nice for that one, but it's not necessary. Okay, so have you come on and sit up. Any questions? And you can go ahead and take your shirt off. And would you come on up here? Take your shirt off, please.